you can see that either isoflurane alone or isoflurane with propofol, and difference in the survival rate of, this is the one on the left side, isoflurane alone, and then as you add propofol, less effect on the cancer cells over a period of all the way up to 3 days, actually. Of course, there are other signals, other papers showing that the early signals saying that there is a volatile anesthetics enhance metastasis in ovarian cancer cells as well. Again, I'm going to show them data. These are all cell-based data showing that you add volatile, there is more cancer cell survival all the way up to 3-4 days. These are all signal. I'm not going to, I don't want you to take a wrong message here. So we looked at it. So one of the best cancer model is breast cancer. It's common and it's easy to discover, and the pathology of breast cancer is such that, and it's easy to understand as well. So Nick Perry is one of our PhD students in Institute of Cancer Research, is currently looking into it. There are some early signals exposing various concentrations of sevoflurane looking at cancer growth. So this is all the way up to 3 days. He's shown the changes in the respiration pattern of the mice and also surviving cancer cells as well. Again, there is a strong hint saying that looking at the lipid control and the propofol, look at this, lung metastasis, and there is some hints. And this is what I'm allowed to show because this is not unpublished data yet, and showing that if you expose them to sevoflurane or a propofol, there is a significant changes in the cancer cell, both in the breast cancer cells and also we are also looking at lung mets as well. So in summary, where are we all? So skepticism here. So there is a biological plausibility saying that yes, there is a hint, strong hint, guys, animal trials studies show. And we need more data on what exactly going on with these various anesthetic agents. Or we have the human data now with them all retrospective or observational. Okay, we need to get to the reality. But it's got a huge impact because, as I said, huge number of operations, cancer surgery coming forecast for the next 10, 12 years. We need an answer. What is the best? How we can make cancer survival better? So you might ask me, Ravi, what's your practice in your hospital? So this is my anesthetics on Friday before I go into the airport on a Saturday morning. If a breast cancer surgery and we use TIVA, I have to tell you one thing about TIVA. I don't know whether in India, because the last time when I heard, we'll still have an issue with the remifentanil. I'm not sure. We can do it with the alfentanil as well. And this is the best pump. If you want to ever buy a pump, it's the Alaris PK pump for the total intravenous technique. We have an electronic patient record system so that nobody can fabricate the anesthetic charts. So nobody can lie that the saturation was 98% throughout the case. This is we use EEG monitoring all the time for all anesthetic. Okay, I'd say all anesthetic, even if it is inhalation, because it's not about this EEG monitoring, not about awareness. It's about how deep the patient is, how you give, how much unnecessary anesthetics you give. So that's why always, if you have an exposure to any EEG monitor, try it on every patient. You will modify your anesthetic technique. With that note, thank you very much. Some of us are around here with the Association of Anesthetists. Once again, many thanks to ISOCOM team, and Jiggy and all the president and Tyagi, Mr. Tyagi and his team. Thank you very much.
Thank you, Dr. Ravishankar. Very nice elaborate talk on what we can do for the cancer patients. And the session is open for questions. Any question more?
First of all, I would like to congratulate on the very lucrative talk, and then it gave a very different meaning, like anesthesia can also affect cancer spread. I'm Dr. Parul Agrawal. Incidentally, my husband is an oncosurgeon, so I'm practicing with him for last 20 years. and I'm head of the Department of Anesthesia in a cancer hospital in Agra. So I routinely meet cancer patients, and since I started my practice, I am dealing with cancer patients as well. One thing I want to know, like you said, you chose breast cancer patients. It's very, like in our setup, we deal a lot of oral cancers because of tobacco chewing in Eta, Etawah, Manpuri, this area. And breast cancer as such, I feel it has a lot of staging in breast cancer, and we get breast cancer patient from rural areas as well. So, some educated patients, they come very early, but there are many patients which come very late. And I had definitely, even I was very inquisitive, the type of anesthesia we are giving, is it causing some spread or not? There was gene mapping also we do in our hospital. And I do not know, I could not make very much difference. I'll definitely try and do it again. But I think we should take this study to a next level also.
Yes.
And we should do in other cancer patients as well, because in gallbladder patients, colon cancers, and it is a very different meaning you gave to anesthesia. Thank you so much.
Yeah, thank you. So, okay, as I said, I don't want you to take home a message that we should start TIVA, look for TIVA pumps from tomorrow. Okay, so we're not there yet, but there are hints. There are strong hints, but I will say that in next 10 years' time, every anesthetist must be accomplished with both total intravenous technique and inhalation technique. I think that's where anesthesia's next jump in heading. And also, we are not far off from, as soon as the balanced trial results come out, not far off from saying that EEG monitoring is a standard monitoring, like end-tidal CO2, how it came. When I was in KEM, end-tidal, it was not a routine monitoring. Then college made an announcement, and then of course the world has changed now. Right? So same thing, we are progressing. Okay, we are spreading the news. Okay.
Thank you so much, sir. I think exactly the point you're trying to make. We have also done a prospective study because of some reports, like you said, where they felt that propofol was perhaps better than inhalational. And we are, I'm Dr. Swagata from AIIMS Bhubaneswar, which is a central government institute. And we deal with very poor patients. So we did an economical comparison. We had BIS analysis for all the patients, both groups, and we wanted to see with the minimum dosages of both we could use. There's almost a 10 times difference in the cost. Isoflurane being 10 times cheaper than propofol for a median duration of surgery of 1.5 hours. Yeah. So we need to really justify the costs, and I think the results will be really awaited.
The cost one, we did our own
in breast cancer.
Yeah, we did our own costing, because in UK less and less people using isoflurane now, because we use more of sevoflurane and desflurane. On the contrary, if you use desflurane and sevoflurane, actually TIVA becomes cheaper. Totally.
Is it justified for a 1.5 hour surgery to use desflurane?
Probably not, but I think at the same time, okay, another thing has changed. For example, 10 years ago, all breast patients used to stay, majority of them used to stay 1 or 2 nights in the hospital, all right? Now, 85% of the breast patients in UK, they go home same day, unless they have a reconstructive surgery. Right. You have a mastectomy, doesn't matter, you come out in the recovery at 3 o'clock, you are going out of the door at 7, 8 o'clock. No drains. Okay, yes. No drain technique. You need a surgeon who understands the anesthetist. You need an anesthetist who understands the surgeon.
Yes, I agree there. Thank you so much.
Recently, few papers have been published about the use of intravenous lidocaine in prevention of the recurrence. Do you have any idea about it?
Yes, I read the paper, but I think it's not conclusive. But
yeah,
I always,
not conclusive. It's very early.
Yeah. So what I'm saying is, it's an infusion. It's not giving infiltration. So as you say, that infiltration is good, but I'm not a great fan of giving infusion. But whether it's a IV infusion or local infusion, probably we are still early stage yet to give a conclusive answer saying that this is one or the other is better.
I am Dr. D.K. Singh from Varanasi. I do a lot of MRM under cervical epidural. But unfortunately, it is published also, but unfortunately, we did not look about the recurrence. So we'll go back and look for it.
Yeah, look at the data.
Okay. So the last question from the chair.
Yes, thank you.
So again, a fantastic delivery. Doctor, I just wanted to understand that, there are a lot of things that we are discussing, and like you very rightly started in your first slide, I think maybe is really whether the total intravenous or the regional techniques, which is better. I just wanted to understand that we should also be looking at, not just the duration of the surgery, but also the amount of products that we have used. Because we know for a fact that blood and blood products also bring about a change in the immunomodulation.
Yeah, the surgery data is coming out soon. There are some looking at robotic versus laparoscopic versus open surgery duration, which metastasis. We are at early stages yet, because robotic, by the time you come out the recurrence data, another 5 years you have to wait.
Correct.
So everything is exciting. Keep reading the journals. That's all I can say.
Thank you.
Thank you, sir, for your nice presentation.
I request Dr. Ajit Gupta, sir, to felicitate Dr. Ravishabkar Rao.
I would now like to invite Dr. Prakash Shastri to deliver his lecture on the management of invasive fungal infections. He is the Vice Chairman, Critical Care and Emergency Medicine at Sir Gangaram Hospital, Delhi. From 1997 to 2007, he has been at various acclaimed institutions in UK. In India, he's worked at Safdarjung and the All India Institute. A senior clinician in anesthesia and now in critical care. He has a number of publications in distinguished journals. He is a teacher, examiner for the FNB and the ISCCM fellowship courses. His other achievements include the fact that he is a member of the editorial board, Indian Journal of Critical Care Medicine, and the course director for the fellowship preparatory course. Dr. Shastri.
Thank you, ma'am, for just a kind introduction. And I must really congratulate the organizers that they have brought in a pure critical care topic into the mainstream in the beginning of the anesthesia conference, because I personally believe that anesthesiologists are the best people to look after critical care, if not for anything else, just for one simple reason that number one, they have empathy for their patients, and number two, they are not biased. Normally, a surgeon would home on to a surgical patient, a physician, a chest physician would home on to pneumonia patients, and so on and forth. So there will be some bias when different specialties come, and there is always a fear among the private practitioners that if I send this patient to a particular chest physician, then my patient will go to him. With me, he doesn't have to worry on that front. So I am more likely to be fair in distribution of resources, in management of the patient, and that's why I congratulate the society today to have included critical care. I know that critical care is an important subspecialty of anesthesia, and like any other subspecialty, you have to really develop some more skills to become proficient in that specialty. Having said that, at the end of the day, you win in critical care if you make a diagnosis, and that is where I say that you have to hone your skills to develop that ability to look into the patient's details and try to arrive at a diagnosis. You intubate the patient, you put lines in it, you give them central lines, you give vasopressors, all that stuff you do, you resuscitate the patient, you make the patient stable, you keep the patient alive for 24 hours. This is just winning the battle. But if you really want to win the war, you have to make a diagnosis. And over the years, what has happened is we have the scourge of sepsis that has come over us, and recently the focus has shifted from just bacterial sepsis, because we always say that when it comes to bacterial sepsis, gram negatives are the ones which are predominant in India and the neighboring countries. So that's why we don't put so much of emphasis upon MRSA. But we were surprised, and we are really surprised, that India is actually a hotbed of fungal infections. The incidences of fungal infections, whatever studies that we have done, and I'm fortunate to be part of a few of them, the incidence is absolutely mind-boggling. And it is just not Candida. It is aspergillus, it is mucormycosis, and mucormycosis, let me tell you, that mucormycosis is one of the biggest risk factors of mucormycosis is diabetes mellitus, and I don't have to tell this august audience that 1 out of every 2 Indians are suffering from diabetes. So we love our sweets and we have diabetes, but we don't realize that we are also making ourselves susceptible to this deadly fungal infections. So in the next 20 minutes, probably we'll talk a little bit about getting familiar with this subject, and when we are accosted with this kind of a situation, how to manage it. I don't want you to refer this patient to me. This is what happened exactly today morning before I came here. A very close friend of mine from Delhi rang up and said, Dr. Saab, main phas gaya. I unnecessarily sent a galactomannan for one of my patients, and that galactomannan has come as positive. Now what am I supposed to do? Then I asked the history of the patient. This patient was a COPD patient who was on long-term steroids, and if that patient tests positive, which is 1.7 of galactomannan, you have a very strong possibility with whatever type of CT imaging that you are getting. This patient has a strong possibility. You have made a probable aspergillosis diagnosis in this patient, and you have to willy-nilly put this patient on voriconazole. If this patient becomes sick and comes to the ICU, gets ventilated, then probably my choice would be amphotericin B. So these are the kind of things that are happening now. The sensitization of doctors have gone up. Their ability to pick up these patients have gone up, and that is why we are getting this. It isn't as though that these have suddenly surfaced. They were there all the time, but the doctors were not suspecting these infections, and that is why they were not investigating them, and that is why they were not treating them. Having said that, intensive care is a totally different ballgame at all. Normally we associate fungal infections with immunocompromised patients, so that's why my topic is after cancer patients. So that was the general feeling, but as I proceed in my lecture, I'll probably explode the myth that fungal infections only happen in the immunocompromised patients or those patients or who are on immunosuppressant drugs. So it's a big problem, 300 million suffering all over the world, and there you can see that the fungal infection is even more than tuberculosis, which has been the scourge of the mankind over so many centuries. The trouble is the mortality. You see the mortality rate, so Candida, it's okay, 30%, it's as high as sepsis, but when it comes to aspergillus and the various kinds of mold, you treat the patient, you have 50% mortality. You don't treat the patient, you have 100% mortality. And so just to highlight, just to sensitize you, what kind of patients, because I want you to realize that these kinds of patients are there in your practice, in your day-to-day practice, and I'm sure you identified this kind of a patient in your own ICU. 64, acute necrotizing pancreatitis, and admitted 10 days ago. So it's 10 days have gone by, the initial period has gone. Diabetic, CKD with a creatinine of 1.8, seizure disorder on carbamazepine. Again, you have to think about drug interactions here. Right subclavian line placed on admission through which TPN is given. That is one thing I really hate. I don't want my patients getting TPN. But yes, in this patient, because for whatever reason, in these good old days when necrotizing pancreatitis was treated, we never fed the patient. We only gave them TPN. So okay, this patient had that, had Foley's catheter, was on piperacillin tazobactam for 10 days, develops fever. So there you can see he's a relatively young patient. He is only 60 years old. He is not 90 years old. Necrotizing pancreatitis, he has got abdominal infection probably because he has developed fever. He is diabetic, is a risk factor. CKD is a risk factor. Seizure disorder, chronic disorders are risk factor. Central line has been placed. That is a huge risk factor. And an even bigger risk factor is that the TPN is being given. Foley's catheter is in place, another risk factor. Piperacillin tazobactam, that is a broad spectrum antibiotic, is being given for 10 days. And you can trust that the moment you get at least the urine culture from this patient, you will have budding yeast cells in this patient. So several risk factors present in this patient. The patient is having organ dysfunction. That means he is having severe sepsis, and you can see the kidneys are affected, the liver is affected. So this patient has gone into multiple organ dysfunction syndrome. So all these causes, central line, pancreatic abscess, urinary tract infection, disseminated candidiasis, and simply SIRS, which I don't accept at 10 days, but maybe in the beginning, that systemic inflammatory response that occurs with pancreatitis, all this could be causing. The question is that now we have a suspicion that this patient has developed an infection, and when we develop an infection, the surviving sepsis guidelines say that First thing, within 1 hour, give antibiotics to the patient after having drawn the blood cultures. So we have drawn the blood cultures. We are now expected to give antibiotics on the premise that you have to hit hard and you have to hit early if you manage to make a dent in the patient's condition. So vancomycin, imipenem, antifungals, nothing, wait for the culture. Now the dictum is, you give a broad spectrum coverage, you give combination antibiotic, so you will give something for gram positive cover and you will give something for gram negative cover. And if the risk factors are present, and I told you what are the risk factors, all these risk factors, necrotizing pancreatitis, abdominal infection, high risk of fungal infection, diabetic, high risk of fungal infection, CKD, high risk of fungal infection, central line, high risk of fungal infection, and more importantly, the lipid that you give in your TPN is a good culture media for fungal infections. So all these risk factors are present. So obviously, I have got no choice but to give broad spectrum antibiotics plus antifungals, and the surviving sepsis guidelines also mention that if your suspicion is there, you are supposed to start, and we'll talk about what you need to start in the next few slides. So which antifungal? Now normally speaking, now in this stage you don't have a diagnosis, so you are doing a presumptive approach in this patient, so probably you will give a prophylactic dose of some drug. Now most of us would agree that fluconazole is something that we are familiar with. Fluconazole is a safe drug, and perhaps when I passed my MBBS, that was the only antifungal that I knew, and the Candida albicans was the only Candida that I knew. So I would only give fluconazole. I will probably look up as to what is the dose that has to be given, but then that is what I would do. So fluconazole, not very expensive. You start the patient on fluconazole. I don't know much about voriconazole. It has got so many drug interactions, so I won't be confident in giving it. Amphotericin B, whether it is the liposomal preparation or the deoxychelate preparation, I know that it has got organ-related toxicity, but more than that, it has got infusion-related toxicity, so I'm not very confident in giving it. Echinocandins are too expensive for me to even think about giving it. So I start with fluconazole. Blood culture comes back and is reported as growing yeast 24 hours. Now, yeast in a patient, fungal infection is definitely there. You can't ignore. You might get budding yeast cell in the urine, in the sputum, and you can safely ignore them. But if you are getting a budding yeast cell or yeast in the blood, that is something that you can't afford to ignore. You have to treat it. And if you have to treat it, you need to know what is the species that is causing the yeast. But at the moment, we have got only growing yeast at 24 hours. So what will I do? The question is that, do I continue with fluconazole or do I add something else? Now, my knee-jerk reaction would be, yeast has come, I can't afford, my patient is sick, I would need to change it. But let us think why. So we need to know a little bit about the species that cause. Now, I have to tell you, and I don't have to quote all the evidence, but for the moment you have to believe me that the most common Candida that is grown in the Indian ICU is not Candida albicans, it is Candida tropicalis. There are various studies to show it, especially the one which came out from PGI Chandigarh, Anurag Chakravarti's study in 2013, which said that the most common Candida in Indian ICUs is Candida tropicalis, and the incidence of resistance of Candida tropicalis to fluconazole is less than 10%, and if that is the case, you are perfectly okay to continue with fluconazole. Having said that, in a place like my hospital, where we track the resistance of Candida tropicalis, my Candida tropicalis resistance is going up to 13%, 14%. So if I have a patient who is very sick, on ventilator, on vasopressors, maybe I'll have to think of giving something else. In my hospital, probably I would lean towards echinocandin, knowing fully well that this is an expensive drug. So fluconazole was continued, patient deteriorated. Now I unfortunately don't have any choice. I have to give echinocandin in this patient, and that is as per the IDSA guidelines 2008, 2012, and now repeated in 2016, revised in 2016, that echinocandins are the first line of drugs in hemodynamically unstable patients, and amphotericin B is an alternative but not the primary therapy. You can think about it. Now that is the biggest problem now this is a global problem. Candida species is identified as Candida auris. How many people have heard Candida auris here? There are very few centers in this country which can identify Candida auris. They identify it as Candida hemoloni, they identify it as Candida rugosa, and those kind of things. I'm sure you have heard of these names. Candida auris is the new kid of the block, and there's a global warning, WHO warning and everything going around that this is a very, very resistant Candida, and generally this surfaces because the infection control practices are not good in your ICU, and it is very, very resistant to conventional antifungal drugs, and perhaps at least by the culture sensitivities of my hospital, echinocandins are the only drugs which probably work against Candida auris. So probably I have to look at echinocandin, but also have to look into the infection control policies of the ICU, maybe inform my microbiologist, maybe I'm looking at a possible outbreak because Candida auris has been associated in outbreaks also, so I have to make this some kind of action on that front. So caspofungin was started, central line removed, the patient now thankfully for us recovered. So Candida auris is not such a deadly bug, but only thing is that it is resistant to various antifungals. So fundoscopic examination was normal, so thankfully for us the patient recovers. So I told you so many of these factors which are present in this patient which were the risk factors, but yes, chemotherapy, burns, abdominal surgery, neonates, hemodialysis, all these are risk factors which are associated, and you can see here that GI surgery, if you have a very good GI surgeon in your hospital, you can see more of fungal infections. So that is something that you need to aware about. The vascular surgery comes close to it. And prior antibiotic exposures, I told you that broad spectrum antibiotics given for a period of 7 days, you can bet your bottom dollar that 8th day onwards you are getting to get Candida colonization at least, if not proper infections. And the most common drugs, most common antimicrobials which are implicated are the broad spectrum like meropenem and piperacillin tazobactam, and within 7 days you can trust at least 10% of your patients would grow Candida from various sites of course, but also from the bloods. And I'm going to talk about Candida ophthalmitis now. The important thing is that even in the best of the center, it's a very, very difficult to get Candida positive in blood. Only the 50% patients actually come out with a positive blood culture, despite the fact they are harboring Candida. And that is why it is important for you to teach your nurses how to send a proper culture. So maybe as much volume that you can send, that is the most important, and you have to take 2 samples of at least 20 ml in those bacterial bottles and send it to the patient, send it to the microbiology lab as soon as possible, because it has a very slow turnaround time, and sometimes we get almost 3 days before we can make a diagnosis. Of course, Malditoff kind of things have come in recently into the hospital, which are actually telling us the species so that we can start the treatment early. So the question is, you have to start the treatment early, because if you delay the treatment by 48 hours, your mortality goes up by 50%. So early diagnosis is very important in early therapy, and that is why we err towards the side of caution and we give presumptive therapy in these patients even when we are suspecting it, and mortality falls from 97 to 52% if I start the antibiotic therapy in 24 hours and the source is controlled. So as I said, echinocandins or fluconazole are fluconazole only if they have not been exposed to fluconazole before. The echinocandin otherwise in hemodynamic unstable patient is the drug of choice as per the IDSA guidelines. And what is important is that you have to take care of the adjunctive measures, emphasize species identification, treat for 2 weeks after resolution of symptoms or 2 weeks after the cultures become negative. Step down to treatment to azole is acceptable provided you can show that your species is sensitive, especially Candida tropicalis. If you grow, you can safely bring down from 5th day, 6th day onwards, you can bring it down to fluconazole. You have to look for deep-seated infections like endocarditis, and you have to do a fundoscopic examination to rule out the possibility of Candida ophthalmitis, because that would change the management. Always and always and always remove central line, even in non-neutropenic patients, because of the possibility of biofilm. There is a lot of claim that the echinocandins and the liposomal amphotericin can actually penetrate the biofilm, but I don't trust that. I have to remove it. That means I have to remove it. I change the site in these cases. And so having so much about Canada, because Canada is a big bugbear in the intensive care unit, I need to move a little bit about the other fungal infections. And the most common that we come across, that I was talking, that I got a call from my friend in the morning, that was perhaps a probable pulmonary aspergillosis. And the interest at this topic has become more recently, because the usual belief was that invasive aspergillosis occurs only in immunosuppressed patients, but now more and more of non-classical patients are presenting with fungal infections, and especially aspergillus, and there are different criteria. One is the BULPA criteria, which was published in 2012, which actually helped you in making a probable diagnosis of pulmonary aspergillosis in patients of COPD. And then we have the BLOTS criteria, which are developed for the ICU patients, which are apparently immunocompetent, but if they fulfill the BLOT criteria, probably you have to make a presumptive diagnosis of fungal infection. So the thought process is moving that seemingly immunocompetent patients are also getting fungal infections, and somehow or other I have a feeling that ICU patients, the moment they step into the ICU, they somehow or other tend to behave as immunocompromised patients, and that is why they become more susceptible to invasive fungal infection. And as we know that more than 7 days stay in the ICU is one of the new risk factors that we have seen. So this is various things. You can see that 47% of the patients of invasive aspergillus patients, even in non-neutropenic patients, have come from the intensive care unit. So it is not very uncommon. The lessons that we have learned over especially the study that we did an invasive mold study in the last 2 years. It is in publications right now, and the lessons that we learned from that invasive mold study, it's going to be published in the next few months actually. That think of aspergillosis even in non-neutropenic patient. COPD is an important risk factor, especially when the patient is on long-term steroid therapy. Serum galactomannan, which I talked in the beginning of my lecture, is not so useful in immunocompetent patients, just like the CT scan may not give you the classical signs as you see them in the immunocompromised patients. So you have to have a very high index of suspicion treated, and instead of serum galactomannan, probably in the next generation, in the next few years, we will be seeing we are hearing more of beta-D-glucan test that is going to come up in this case. Treatment of choice in aspergillus is voriconazole and voriconazole. The alternative therapy could be liposomal amphotericin B. Salvage therapy would mean combination of various drugs that you can think of. Few comments upon mucormycosis. Why we are seeing only the tip of the iceberg? Because there are a lot of patients of mucormycosis, because we don't diagnose diabetic, and these patients come in diabetic ketoacidosis, and that is when the diagnosis of rhino-orbital or rhinocerebral mucormycosis is made. And so these are the various manifestations that you see, and the classical manifestation that you would see is this lady there who has come with a rhino-orbital mucormycosis. I could save this lady only by right eye exenteration, and besides a very, very radical debridement, endoscopic debridement of the nose, we could save this patient, and this patient was treated for as long as 6 months. And even now I get messages from her that I am seeing this New Year because of you, and I am seeing this Diwali because of you. So it's a very satisfying thing, but you have to accept that the treatment is mutilating. You have to have very radical debridement surgery. The drugs have to be given all right, but the surgery is a very important component in managing these patients. So whenever possible, do surgery. Very high doses of amphotericin B. A new drug has come up, posaconazole, which is now available in the intravenous formulation also, which can be used as a synergistic drug. Normally we give it upfront. In my hospital we give it upfront, but generally in the other hospitals, because it is available in the oral format, they give amphotericin B for 4 weeks. They overlap posaconazole with amphotericin B in the last 4th week, and subsequently send down the patient on oral posaconazole, because the problem with posaconazole is its bioavailability is very poor, its intestinal absorption is very erratic, and that is why we are not too sure what are the drug levels of this patient. So this is a wonderful case for therapeutic drug monitoring. I will not talk about that. But posaconazole, if it is given continuously for 7 days, then possibly second week onwards, you can trust that you have adequate blood levels to discharge this patient on posaconazole. Thank you very much for your patient listening. I know this is so much different from anesthesia that you have been hearing, but I'm really glad that we have included this topic, because I'm sure in the years to come, in the months to come, even the newspapers would start telling you that India is going to become the capital of fungal infections all over the world. Thank you so much.
Thank you, Dr. Shastri. That is a very informative lecture on the requirement and the fungal infections which we are seeing today. I'll open the floor for any questions. This is a little out of the way of the topic, but when it comes to antifungals, how necessary in a transplant situation, because that is another space that we are entering into from the anesthesia perspective. So how relevant would you think an antifungal prophylaxis is in a patient who is probably already has some pre-existing conditions, is going to be immunosuppressed following the surgery?
Prophylaxis in transplant patients, normally the kind of work that I have personally done, when we talk about prophylaxis, we talk about fluconazole and fluconazole only, nothing else. But yes, things have moved. It all depends upon the flora and fauna of your hospital. What is the incidence of Candida tropicalis? What is the incidence of resistance to fluconazole in Candida tropicalis? But let me tell you, very, very good news, various places, Dayanand Medical College Hospital, for example, the anesthetist picked up pulmonary aspergillosis in a patient in the second week of therapy. So you people need to have an idea, and I'm really glad that I can even name that person who was the first, it was the anesthetist who actually picked up the fungal infection after a liver transplant patient. So yes, you need to be aware of these things. Prophylaxis is institutional protocol, I would say. You have to develop, every institution has to have its own protocol. It should not be left to the whims and mercies of the transplant surgeon, who is the prima donna. But having said that, normally speaking, I would stick to fluconazole. It's very hepatotoxic safe, it is very safe from the kidney point of view, and that is why these are the two transplants that I have really been familiar with. And in these two situations, I would give a drug which will at least not harm the patient. So my choice would be fluconazole prophylaxis, unless of course the burden in my hospital is very high when it comes to fluconazole resistant strains of aspergillus and mucormycosis. These are diagnoses which are made later on. They don't happen so early, but you have to be very much on the lookout. Aspergillus especially, we have diagnosed several cases of aspergillus as early as second week of transplant of liver. Kidney is an absolutely different ball game. There the incidence of PCP becomes very high, so that is why we need to give PCP prophylaxis in those patients, and generally these patients are on Septran. The nephrologists are very good in prescribing Septran to these patients, but in liver transplant patients, fluconazole is the drug of choice, I would say.
Thank you. Thank you, Dr. Shastri. Thank you so much.
Can I ask you a question, sir? Hi, sir, Atiyarsh. Thank you so much for a wonderful presentation. Sir, I have a question regarding posaconazole. Do you use it as a co-therapy, or do you use it more as a kind of continuation of therapy after you have used echinocandin? I have one more in conjunction to
I don't use posaconazole with echinocandin.
You use it as a continuation?
I use it only with amphotericin B, never with echinocandin.
So the thing is, what's your experience with using IV posaconazole? Some companies have come up with the IV posaconazole because they had some reservations using oral therapy.
I told you that posaconazole is very, very erratic when it comes to absorption from the intestinal tract, and that is why we need to give it with milk, with curd sometimes to increase the absorption. Having done that also, we generally, when we are giving amphotericin B to the patient, we give it in tandem, we give it together. We give amphotericin B as well as posaconazole for 7 days, after which we think that the posaconazole levels in the blood would have stabilized. Then we switch off the amphotericin B. So that is the standard therapy. But nowadays, because of the availability of IV posaconazole, what we have done is that we have now upfront, the moment we diagnose mucormycosis, we start upfront both amphotericin B as well as posaconazole because of the availability of the IV therapy. But my experience in IV, because it has come only recently in the last 2-3 months, it's a bit too less for me to make any judgment. I would only prescribe IV posaconazole in those conditions where I have doubt about the intestinal integrity, like in those patients with mucositis and so on and so forth, or patients are so hemodynamically unstable that I can't give them orally. So these are the only indications that I can think of at the moment, but my experience is that of only 3 months, so it will be presumptuous on my part to even make a comment on it. But yes, it has come, but more importantly, having said that, I'll use this opportunity to say that a wonderful drug called isavuconazole has been introduced in the US market. It is just a matter of time. It is effective against both aspergillus as well as mucor. So maybe that would be the drug which I can think of giving as a prophylaxis, because there I don't know what I'm dealing with. So isavuconazole would be a drug of choice if I'm thinking that I might be dealing with both, or I don't have a diagnosis. So that is something available both in oral form as well as IV form. You can't give it through the rice tube, but IV, yes, you can give it, and that will be a wonder drug in the next few months or years to come. Thank you for your question.
No more questions? Thank you so much, Dr. Shastri. Thank you.
Thank you, sir. Now, I request Dr. T.C. Pipple, sir, please give a token of acknowledgement to Dr. Shastri. So, with this wonderful session, we are ending here, and we'll meet post siesta after an hour after a lunch break.